So much for joining. Hi, everyone. Thanks so much for joining. Just a few Zoom etiquette kind of things to get started. I know we're all pretty used to this by now, but mute yourselves when not talking. We'll probably save questions maybe till the end, just because we're starting a little bit later. So go ahead and post questions into the chat and I'll kind of monitor that and we'll give them to Sandra and Heather at the end. And then also at the end, there will be question time. So people would be able to unmute or raise their hand or anything like that to be able to ask questions. Otherwise, we'll get started. I'll do a couple of introductions and I want to really thank Heather and Sandra for joining us today. I would refer to them as maybe spinal cord injury royalty. They've been in this field for a long time, and I know I reach out to them occasionally for questions and help. So thanks so much for them for joining us. So first off, Sandra, she started her career as a therapeutic recreational specialist and worked with people with spinal cord injuries at Lyndhurst Hospital, further expanding her clinical experience to palliative dialysis and complex continuing care. She's also worked in the employment services where people with SCI, injury prevention and teaching at a post-grad level. She's obtained her Master's of Education, came back to UHN at Toronto Rehab Lyndhurst as a patient education and engagement lead, developing educational tools and resources for patients, family, staff, and increasing staff capacity and education excellence. Her work focuses on patient experiencing and ensuring that they're part of the decision-making and program planning. And she's a co-lead with Heather on the patient-oriented discharge strategy initiative. So highly qualified. Heather is an advanced practice lead for spinal cord injury rehab at UHN Lyndhurst. She has over 20 years of experience in the field of spinal cord injury rehabilitation as a physical therapist, and for 8 years prior to her current role. She's an advanced practice leader role, or has that as a role, and she supports clinical research integration and leads projects to advance best practices in SCI Rehab. She's been an active member of the Ontario Solutions Alliance since 2010. She's on the board of directors for the SCI Ontario, where she serves as the chair of the quality committee. She's a lecturer in the physical therapy department at U of T and completed her master's in the graduate department of rehab sciences, focusing on walking outcomes for incomplete spinal cord injury. She has expertise in the area of walking, pressure injuries, best practice implementation, and health service delivery and outcomes. And she's a co-lead of the Teach Back SCI PODS initiative and a site lead for the Ontario SCI Consortium and the Toronto site co-lead of the SCI Mobilization Network. She's authored a number of articles and book chapters and presented at many conferences. And again, thanks so much to Heather and Sandra for their presentation on supporting community transitions from spinal cord injury rehabilitation before and during the COVID pandemic. So I'll turn it over to you guys.
Hello, and thank you. We are thrilled to be here and interacting with everyone. I do have to say, Jamie, though, Dr. Milligan, that Heather and I are less than proficient at Zoom. We have been on site every day and have not had to use Zoom for a lot of our work. So you are the professional in that regard. And so we will do our best to not get dropped throughout the course of this presentation. It's one of the skills we didn't develop over the past 18 months. So I'm Sandra, this is Heather. The agenda for today is just to kind of reflect on what quality transitions actually mean for the people on the call and for us. We're going to talk a little bit about pre-pandemic initiatives here at Lyndhurst and then the post-pandemic adaptations and initiatives. The challenges, and there's always got to be a silver lining. So the silver lining that we experienced throughout the pandemic, and then we're going to open it up to a little bit of a discussion. So just if everyone can take a minute and from your own experience with discharge from a healthcare setting or from perspective of you yourself as a person with lived experience, think about what's the most important information that is needed when you transition from one environment to another. And I want you to think about this in two different ways. What was the information that was needed prior to the pandemic? And then during the pandemic, what do you think was most important? So if people want to throw some comments in the chat, they can do that. Or if they just want to write them down or reflect silently, however is good for you, that's great. And Jamie, I will be guided by you if there's anybody in the chat that has said anything.
So I added follow-up with who, both pre and post-pandemic. So sometimes there's some confusion about who to follow up with. I see Jocelyn from SCI, Spinal Cord Injury BC, has said, you know, who can answer my questions about spinal cord injury and where to get help with complications?
Yeah, really, definitely questions that we've had here as well. Okay.
Okay, so, and I just want to note, Sandra and I are more than 6 feet apart, so I am going to take off my mask to speak. Otherwise, my glasses will get all steamy and I won't be able to see the slide. So, but we are more than 6 feet apart, and we've both been fully vaccinated. So, just to start with, I think this group, obviously, this is not new information, but I just wanted to first acknowledge, when we think of spinal cord injury, we know that it is a complex, multi-system, life-altering condition. Affects the person, their care team around them, their family, and we know from the literature, as well as from our experiences, that people with spinal cord injury identify that transition from rehab into the community as overwhelming. We hear things like people saying they feel like they were dropped off a cliff, or just that transition is so overwhelming. So Sandra and I in particular, over the last 10 to 15 years, have really been trying to think of what we can do to help with that transition. So that's what we will talk about, and then we'll talk about how that changed over the course of the last 14 months. So just a little looking back and looking forward. I think probably there's many of you on the call who remember the golden days, as some people like to say, of spinal cord rehab. So I just tried to reflect back a little bit to think of back in the past. So even when I look back as far as 2008, our patients stayed a lot longer at that period of time in inpatient rehab, and the average at that time was 82 days. But it wasn't unheard of for people to stay in inpatient rehab 6 months, a year, and if not longer. But particularly for our center at Lyndhurst, one of the things we were hearing was that people couldn't get into rehab. So there was lots of people who needed inpatient rehab, but at that time there was only about 100 to 150 patients that were seen at Lyndhurst each year. So that was something we were really charged as a program to say, how can we ensure more people have access to inpatient rehab? So over time, we've tried to be more objective and tried to really think about how to decide how long someone can stay in rehab to ensure more people get to inpatient rehab. So right now, our average length of stay is about 56 days. So that can range from as short as about 20 days all the way up to 110 days or longer. But certainly that absolutely is shorter than it was before. So time has been condensed in inpatient rehab. But the other thing that's really changed is the acuity of people coming into rehab. So previously, it used to be that people would stay in acute care for many, many months. And now we're seeing patients coming as early as the week of their injury. So it's not uncommon to hear a patient coming here 3 or 4 days after their accident or surgery, with the median time being around 14 days. So you think we're shifting everything much sooner. So people are still in that very early stage, first of all, of recovery, post-surgical complications, but also that very, very early period of adjustment, of spinal shock. All of those things have really shifted to more of what we would consider almost a subacute rehab facility. So when you think of when people stayed here longer, there was certainly a lot more time to adapt to life changes, to learn new skills, For me as a physiotherapist, when I was practicing clinically, you really wanted to make sure all of those fundamental spinal cord injury skills were learned during inpatient rehab. So that was certainly a positive, but I think Sandra and I have also reflected on the structure of our inpatient rehab was much more didactic. It was an information push. It was telling people what they needed to know and learn. But now when we look at our current state, certainly people spend a lot less time in inpatient rehab. So there's a lot less time for that adaptation to such a significant life change. There's a lot less time to learn new skills. So the focus has been shifting towards self-management, problem-based learning, learning those fundamental skills, but recognizing that a lot of the learning and the rehabilitation will happen after that inpatient rehab period. So another thing that's changed, it used to be that patients would have many patient care conferences or family meetings when they were here. So time to talk as a team with the patient, their family, significant others, to talk through that discharge planning early on, the middle of their stay, and closer to discharge. Now we typically have one patient care conference or family meeting during their rehab. Again, when you think of them staying longer, there was multiple opportunities for community outings, day passes, weekend passes, lots more experience in terms of interacting in the community. Again, just with the likelihood of less time, that has shrunk. And then the last thing is patients used to be, for the most part, when they were discharged to their more permanent setting. So typically to home or where they were going to be staying for a longer period of time. So there was time for home renovations. There were time to secure new accessible housing. Now, more often, we see people moving into a transitional or interim discharge location or plan. So it might be that renovations haven't occurred, or someone really wants to live in the city for that first year or two to be able to access services before going to a more rural location. So, lots of different changes, but I think there's some important things that we've reflected on that actually are positive. We've really had to shift in how we provide rehabilitation to make sure it is more prioritized to what a person needs in terms of that first transition into the community. So how did we adapt to support those patient transitions into the community? I think as a team, when we really talked and brought together the team, the things we recognized we needed to do, we needed to be more collaborative, more efficient, and interprofessional. So not one person owning anything, but we really have to come together, recognizing having the person with a spinal cord injury in the middle of it, but then us all working together to share those responsibilities and to be collaborative, to make that time in inpatient rehab as beneficial as possible. And to do that, we knew we needed to integrate things that you would think should be really well integrated, but for us, they were not necessarily. So we needed to think about the patient education that we provided, how we provided it, how that related to the goal setting that we would do with patients, and then how that related to transition planning. So previously, it had been a little bit separate. So patients would say, these were my goals, but then the team was talking about, these are the things you need to do for discharge, and we weren't making sure those were connected. So how did we do that? How did we do that? Press the try to enter.
Sorry, the screen's frozen. So from a patient education perspective, I revamped what I affectionately call the Getting Started Patient Education Program. So this is a series of 12 half-an-hour sessions that are all problem-based learning. The intention is not to push information onto people, but it's really to get people to start asking questions based on the content that is in each of those sessions. All of the sessions are evidence-based and are based on the expressed needs of people with lived experience in rehabilitation. Spinal Cord Essentials is our patient education materials that is online, and so a patient will come to Lyndhurst and get a base binder And then through the course of their rehab, they can choose up to 80 different handouts based on their needs and interests, and add that to the binder, take it home, and it is then their customized patient education tool. SCIU, with the help of John Shepard, was created here at Lyndhurst as well as across the country. There was a whole lot of people involved in that. And we still frequently use those SCIU videos to help enhance learning. The other big thing that took place was really staff skill development. And because there was this shift to self-management, people needed to know how to become a self-management support. So if we want patients to be good self-managers, what role do we play in that? And that was through a lot of information on health literacy, plain language, cultural competence, healthcare communication skills, all of those things that an individual clinician would need to know to work with and for a patient.
Okay, and then when we looked at goal setting, I think we recognized that when we look back at our previous approach to goal setting, when we spoke to patients, when we spoke to staff, and we reviewed charts, we would see that the same common goals would be reflected. It would be, I want to walk. I want to get my hands back if someone had tetraplegia. I want to go home. But there wasn't the broader, all of the other things that are priorities or important needs in spinal cord injury. So we wanted to make sure we broadened that to really cover all of the areas of spinal cord injury. So as a team, we sat down, we talked to patients, we talked to all professions to say, what are all of the areas of spinal cord injury, or what are all of the domains of spinal cord injury? So if anyone's come to Lyndhurst, you will see this poster everywhere in the hospital, in all the inpatient units, in outpatients, in our therapy areas. And it covers the 26 domains of spinal cord injury, including things like bathing, bowel, bladder, sexual health, respiratory function, all of the potential areas that can be affected by spinal cord injury. And then what we really wanted to highlight is that in all of those domains of spinal cord injury, the person who's most involved and will be affected by that is the patient. So you see that first column being the patient and then the family, but then helping patients to understand all of the team members and supports that are involved and who they can go to for questions. So a common example we also often give is the area of sexual health. So that's something we know from the literature, from speaking to patients, that is a priority for people with spinal cord injury, but often doesn't get raised as a question. So that was one way for us to explicitly put that this is an area of spinal cord injury that we have expertise on, and these are the people you can talk to. And so that really recognizing that patients can have priorities, so the things that are most important to them, and things that might initially be needs. So someone might not identify a goal around bladder management immediately, but it's still a need for that to be addressed, and the team will help support that. So that's how we really tried to shift our approach to goal setting to really make it more collaborative and covering all the areas of spinal cord injury. And then the next part was around thinking about transition planning. So if you remember me talking about how much shorter our length of stay is, so with time compressed, there was a few things we heard from patients that was important. One was that they needed to know sooner when they were potentially being discharged. So they didn't want that to happen as far out as a month or at that family meeting, but they wanted to have some advanced sense of that. So not necessarily written in stone, but just to give a sense of time frames. So we've set a timeline to really try to provide that information to families and patients within the first week of their admission. So giving them that tentative discharge date sooner to help for planning. And then also to shift that patient care conference or family meeting earlier. So again, having that happen within the first month, depending on some patients that might be as early as a week or two in, others who are staying longer that might be shifted out closer to a month. But really, again, trying to help people have all the information they need and have those questions answered early on. And then the other area that hopefully helps our colleagues like you in the community was we really tried to think about how we provide discharge information to other healthcare providers, to community providers. So what we did, we again followed that same structure of those domains of spinal cord injury, so those 26 areas of spinal cord injury, and we have one interprofessional discharge summary, separate from the physician summary that would also get dictated and sent to family physicians. This is across all of the professions, and again, it covers each area, and we really wanted to make it focused on if there are any current issues, what is the issue, and what is the plan and the follow-up for that. So making sure things haven't been forgotten, things like what is the plan for respiratory management? Will the patient continue to do volume augmentation or breath stacking? Have they been taught to do that? Do they have the equipment they need? So really trying to make sure we cover off all those things. And then there was still a gap, and I think this is where we came upon something that we were very fortunate to have, and that's TeachBack SCI PODS.
So you may have heard of PODS, Patient-Oriented Discharge Summary. Heather and I really wanted to rebrand that because we have taken a unique approach to PODS here at Lyndhurst, and so we affectionately call it TeachBack SCI PODS. We were one of 8 hospitals back in 2015 who were part of the early adopter initiative in Ontario, and this was through funding from the Toronto Central Local Health Integration Network in partnership with Open Lab at University Health Network. So in a very short period of time, if anybody is familiar with project development and implementation, it was probably less than 3 months. What we did is we built a project team and we had 2 patient advisors. So these folks had been through the program at Lyndhurst and they sat at the table with us and were very vocal about how this initiative should look, the role of the patient, the questions that should be asked, the timing of the interview, and all of that. So they were completely co-leads with Heather and I and the other project team managers. Early on, we conducted patient and staff focus groups and interviews to identify the barriers and enablers to transition and to discharge so that we got a sense of what it was that was important for people. We then took all of that information and piloted some information with patients to find out if that would resonate with them. But then also patients told us differently about different things that came up when we specifically asked them questions related to this initiative. We built a template and a process. So this is not just a form that gets completed and is given to patients, it's much more of a process that happens. We did all kinds of staff education, and then there was an implementation that happened near the middle of March with an evaluation happening just after March 31st. So really the goals of TeachBack SCI is to consolidate rehab learning, to identify outstanding needs before discharge. So this was an opportunity for people to share with the people in the meeting that they didn't have information about a particular topic, or they were still unclear about how they were going to manage their skin or get food into the house. Through talking aloud what somebody has learned, it helps to reduce anxiety prior to discharge. And you can actually see that happen in people in a physical manifestation. But it also helps to enhance self-efficacy. So what is TeachBack SCI PODS? So the first thing to know is that it is a meeting, and we use TeachBack. TeachBack is a process by which you ask somebody to speak aloud what they know or what they have heard over a course of time, and that meeting uses the approach of nice, big, open-ended questions and self-management best practices. The meeting is led by a neutral clinician facilitator who is a clinician here at Lyndhurst, but is not directly related to the patient's care team. So in a lot of cases, it's outpatient staff or service coordinators. Some people from our assistive technology program are also involved, but that person is not directly related to the care team. The reason that we went with a neutral clinician facilitator is because when we pilot tested somebody from the team asking the question, so tell me what you know about your pressure relief strategy. And the patient would say, I don't know, I'll probably move side to side twice a day. And then the therapist would say, oh, it's okay, I know that we talked about that stuff. I know that you know it, so don't worry about it. And what that does is it shuts somebody down and doesn't create that opportunity for discussion and dialogue. So the areas that we focus on through that meeting that get transcribed onto the document is information about confidence in medication taking, the individual's care plan through the 26 domains that Heather talked about earlier, the signs and symptoms. This is kind of the worst case scenario, the things that we never want to have happen, but is always good to plan for, follow-up appointments post-discharge, and then an individualized contact list so that the person would know who to call should they have any concerns in the first few weeks at home. We do this meeting 1 week prior to discharge, write up the summary in the patient's words, so pee, poo, baby mama, whatever it is that the individual says, that's the words that get written onto the document. We refrain from using any sort of medical jargon or short forms. Who's at the meeting is the patient and or family member, the facilitator, and a member of the team. There is a member of the team at the meeting, and their role is really to be a strong, silent, contributing person. So they don't say a lot until they are called on, should there be questions or concerns that the facilitator and the patient are not able to answer. This is the template that we use, and so you can see over on the top, we get somebody to identify when they were admitted, when they're leaving, where they're going, what their diagnosis is, whether or not they have a binder. We talk about confidence in taking their medications, and then review how somebody will have those medications renewed on an ongoing basis. Make sure somebody has their GU prescription list, and then go through all of the different areas that could be impacted by their spinal cord injury through the care plan, signs and symptoms, and then the follow-up appointments. So if some of these things don't apply to a person, for example, somebody with a incomplete paraplegia would not necessarily have swallowing and breathing as a concern, so we would take that off of the template, and then it becomes that much more customized to the individual's discharge plan. So as of May 2015, we went into full implementation with, at this point in time, about 97% of all patients going through this standard of care. We've had different facilitators come and go. Some people have decided that their caseloads are too heavy and they need to rotate off the schedule. But at any point in time, we have 8 trained neutral facilitators who are familiar with the concept of PODS, self-management, open-ended questions, and reflective listening. We have about 40 clinicians from 8 different professions who actively participate as the team member in those meetings. We have 3 schedulers, as you can imagine, trying to schedule anywhere from 4 to 8 discharges a week can become a little bit overwhelming, so we actually have dedicated schedulers. This project had no additional money or resources, so it was all within the current context and staffing that we have at Lyndhurst. We received excellent feedback from both patients and staff. Patients often will talk about how they feel a lot more prepared to go home, that they didn't really know what they knew until they spoke aloud what they knew. And staff often saying that they were so surprised to hear somebody say that they could do all these things at home. Heather and I have often had staff come to us and say, this PODS is going to be a terrible, person doesn't know anything, it's going to be horrible. And yet when we go through the process, the individual is able to articulate what their care plan is when they get home.
Can you just shift back 1 sec? Thank you. I was just going to comment one other thing that I think surprised us, but another kind of added benefit of PODS was to the clinicians involved. It has been a really effective reflective practice tool. So I think when you're hearing patients talk back what they've learned, it helps give you feedback on your practice. So a few examples we had early on was we were finding when we would talk through the skin health and pressure injury prevention scenario, patients were able to teach back how they would pressure relieve in bed. That was very consistent. They would tell us how often they would turn, how they would turn, what their plan was to do that. But then when we got to talking about pressure relief in the wheelchair, there was so much variability. And that was because there was variability or inconsistency in what clinicians knew and what they told patients. So that was a really good way for us to give feedback to the staff and how to adjust what they were teaching so that there was consistency with patients. The other one was around the area of what to do if you fell at home. So particularly, what would you do, how to get up off the floor? Is that something you could do on your own? And if not, what would be your plan? So I think for the physios in particular, that was a really good feedback to say, this is something I need to make sure I've talked through with patients. If it's someone who's not ready, not everyone can do a floor to chair transfer. Not everyone can stand up to get off the floor. But to make sure everyone was planning for that worst case scenario. So that was something I think it was a really helpful way for people to reflect and change their practice. So now we're going to switch gears and really talk about then what happened with all of this work that we've been doing when the pandemic hit. And I'm sure for all of you, it certainly changed your lives, how you practice if you're a clinician, how you work in the community. We know it changed everything. So for us, the initial impact, when the World Health Organization made that announcement in mid-March, the initial very immediate impact for us was right away. There were no visitors, no family members, no volunteers, and we could not have any external caregivers inside the building. So that was huge. The other thing that immediately changed was that patients were no longer able to go out into the community for community integration outings, to go to Tim Hortons, to go to a grocery store, to go on a home assessment, or to go out on a day or weekend pass. And if anybody has experienced rehab, has worked in rehab, you know how critical that is to inpatient rehabilitation. So that part for everybody, I think, was a huge thing to think of, oh my goodness, this is a lot. What are we going to do to manage in this time to help support patients who are still coming for their rehab? So we were also no longer able to use the Lyndhurst patient apartment, which is something that offers people the opportunity to practice the skills they would need inside an apartment, self-enclosed apartment within Lyndhurst. Peer support, so we typically have SCI Ontario peer support on site. They were working virtually, so that again, we lost that ability to have the face-to-face peer support. Our inpatient dining room then got closed, so there wasn't that same opportunity for communal dining. And then on the outpatient side, we immediately had a shift to only essential outpatient clinic appointments. So really what continued in person were things like our Robson urology clinic, our skin and wound clinic, things that were essential to come in person. And then all of the other things were virtual. But for outpatient therapy, again, there were no outpatient therapy appointments, so we really had to think through how to provide support for those patients who were in the midst of their outpatient physio and OT, how to set up home programs where possible. And then the picture there you can see, so a lot of our outpatient staff right away were temporarily redeployed to things like screening booths. So what did we do to respond initially? So probably like everywhere else, we really had to think of how we could use technology for family communication, so for people to interact with their families, but also for teaching. So using things like FaceTime. Our assistive technology service became essential for people either who didn't have the ability to access technology, either physically or through because of lack of technology and knowledge. We also had to change to use things like Google Maps, videos, getting photos for home assessments to take the place of visits and outings to understand the community environment. And then we really had to start planning for what we could do, what more we could do to support patients. So then, probably just before Easter, we then redeployed our outpatient staff to support inpatient services. So that created the opportunity to spread out our staffing. So we went from having therapy staff here 8 hours a day to fully 12 hours a day. And we then had staff here 7 days a week. So going from 5 days a week of therapy to 7 days where possible. We looked at how much downtime patients had. You can imagine the time patients would typically spend with family and visitors. So we extended our gym hours into the evenings and weekends by using that additional staff. Where possible, and appropriate, we intensified therapy, so provided more therapy, and really tried wherever possible to enhance opportunities for skills that people would typically do when going out on passes. We increased leisure and recreation activities. And then the other area we really needed to support was things like laundry and feeding and facilitating family visits over Zoom and FaceTime. And then there was a new initiative. So we really brought together the team and said, what is missing right now and what can we do to support it? So our community integration program, which had already existed, our therapeutic recreation group really had to rethink that to, again, make that virtual, to use videos, to talk together as a group rather than going out, but still talking through some of those scenarios. So planning for trips, what you need to do, transportation, having emergency plans, all of the different considerations on going out, how you will interact with others. We collaborated with Spinal Cord Injury Ontario to develop virtual peer support. So those peer support coordinators were then coming in virtually to hold sessions with patients. As we already talked about, developing those weekend and evening programs. And then we collaborated with Team I Will and had a past patient speaker series. And you can see here videos or images of patients talking about their I will statement. So really trying to motivate and support people, recognizing they did not have the opportunity to have family, visitors, and all of those other peer supports when they're during this time. So I think we really recognized how important Teach Back SCI PODS became. So we really saw the value of it. It really heightened the importance of consolidating the learning. We really had to place a lot more emphasis on preparation for having that social isolation at home in the context of stay at home. And there was a lot more talking through scenarios to ease anxiety of going home and expectations when recognizing that people did not get to go out of Lyndhurst. So other than maybe going to a medical appointment, there were no outings, you were not able to go home to see what things were like. And then also really having to address some of the fears around COVID and providing additional resources. So what were the biggest challenges? Certainly at 100%, the isolation people experience from family and friends. I think that's the part we really don't understand the magnitude of that unless we've lived it. But I think it's certainly for all of us who've worked at Lyndhurst for a long time, it overwhelmed us thinking about it. And really thinking through the lack of opportunities for community integration and practice. So thinking of individuals coming to Lyndhurst, an environment where the majority of people are in wheelchairs and working with teams who have experience in spinal cord injury, not having that experience to go out in the community and what that feels like interacting in the community. The other big challenge for us, which I'm sure was huge in the community as well, was the whole issue of PSWs, finding PSWs, people having concerns about having PSWs in the community, and that was certainly something that created delays in discharge for us. And then the impact on outpatient therapy. So we had to stop it. So again, that stoppage for those individuals who are in the middle of outpatient therapy and those patients who were discharged and then were not able to receive outpatient therapy. And I think we all could acknowledge For some areas of rehab, virtual therapy works, but it was very limited for us, particularly in spinal cord injury, for physical therapy, for OT, where people might be practicing transfer training, learning to walk, a lot of the physical tasks that you really needed to be in person to do. But there were silver linings, and I think we certainly have reflected on those. One of the things we want to ensure we keep where it makes sense is for our family meetings and patient care conferences to enable those to be virtual when it's not easy for families to come in. So if someone's traveling from afar, to have those opportunities, to have them join a family meeting without it having to travel, down to Toronto if they're coming from Barrie. Again, having those opportunities for virtual teaching and education, both on the inpatient and outpatient side, I think that absolutely must continue. And then the other thing we've really reflected on is the enhanced sense of community that is inherent in Lyndhurst, but we've really seen it more. So it's more, I think everyone's been more exposed to it, that patient-to-patient peer support, when there's, there are no families and visitors, or there were none at the beginning. So we've really seen that sense of camaraderie, and how do we support that going forward? So just to conclude, I think we've highlighted, I hope we've highlighted that our program has really tried to adapt to really support transitions in the communities for individuals with spinal cord injury. We've seen how Teachback SCI has been really valuable addition, particularly during the pandemic. And the adaptations and new initiatives that we implemented were really to support patient transitions during COVID. But I think we really acknowledge, and I think we'd love to hear from you, the true impact of experiencing a spinal cord injury during this period isn't known. We don't know what has been that impact. I think we have thoughts around it, but I think that's something we really are reflecting on as we continue to proceed with this.
So we're looking to you in the community to help us close the pandemic feedback loop. And just some more questions to think about. So from your perspective, what effects have you seen on people with spinal cord injury after discharge from rehab? And what do you want us to know from the community perspective that you think would help make our program better? Hopefully we don't go into a fourth wave, but if we do, we want to continue to be able to use the initiatives and adaptations and make them even better yet for the people who are to come later. So we will conclude there. Thank you very much for your attention, and open it up to discussion and dialogue.
Thanks so much, Heather and Sandra. That was great. It's such an innovative program, and so wonderful to see how flexible it's been through these tough times. So there are a couple comments, and there is one question in the chat. Maybe I'll start with the question in the chat first, and then others can either put some questions in there or unmute, and we can get to it. But Gwen Zowenko was asking, what's the length of time needed for the Teachback discussion?
So the Teachback SCI meeting takes anywhere from half an hour to an hour. The average really is 45 minutes. For somebody who doesn't have a lot of complexity, we can bang those meetings out in half an hour. But for somebody who has a higher level injury and their spinal cord injury has affected all of the domains of care, it very well might take up to an hour. The other thing that makes those meetings a little bit longer is when we need to use an interpreter so that the individual fully understands what's happening. We want to be able to communicate in their language, but that increases the time required for the meeting.
Great. Anybody else have any questions or comments? If not, I do. I was just wondering, you guys really outlined like some of the challenges, with COVID and that sort of thing. But I was also just wondering if there's any, and you sort of mentioned it in terms of staffing, but I was wondering if there was any other particular challenges that you sort of identified with the Teach Back SCI PODS program, things that you had to adapt to or other challenges. For example, I did think of staffing. I was also thinking about whether mental health issues ever played a role. Perhaps it actually, brought those things more to light, but just some thoughts on some challenges that you've encountered over the years.
Yeah, I think one of the things we learned over time, so when we talked about having a neutral facilitator at the beginning, that facilitator was completely neutral and often would go in knowing nothing about the patient. And I think all of the facilitators over time have learned it's probably good to get a little heads up from the team just to know, is there anything we need to be aware of, just to make the meeting as beneficial as possible for that patient. So around the area of any mental health concerns, so we will oftentimes, it's the social worker or psychologist who is involved in a meeting like that. And we will also get them to help guide if there's an area we shouldn't talk about. So, if it's a patient who's really struggled with depression, around social isolation, if there's an area that we know it's going to make things worse rather than better, sometimes we will tailor the meeting. And I think the facilitators are all pretty experienced at doing that. But Sandra and I typically are the ones who do the more complex pods, and we really try to navigate those scenarios so that, again, the meeting is helpful and not exacerbating something. So I can think of a PODS, doing a PODS with someone whose spinal cord injury was the result of a suicide attempt, and really having the psychologist guide that to what to talk about and not talk about. So I think we've really tried to navigate those, but really tried to continue to do PODS with everyone. Because I think at the beginning, the teams would often say, no, you shouldn't do PODS with that person. You shouldn't do PODS with that person. This person doesn't need a PODS. I think so that's one of the challenges we've really tried to work through and really try to tailor it to what that person needs.
I think if I can add on to that, during the pandemic when we were doing PODS and, we would have family members here and an individual had a higher level injury and was requiring PSWs, and Heather spoke about that earlier, and you could just feel the tension in the room go up when the discharge date was approaching and that individual still didn't have PSW support in place because they simply couldn't find any PSWs. And the anxiety in the room would be quite high, and we as facilitators needed to manage those conversations and try and bring everybody down by talking about what that individual had learned in order to manage their care with or without a PSW, so that they could kind of get what we wanted them to get through that meeting. And that was a sense of self-efficacy and self-confidence in that discharge process.
And I think the other thing I'm thinking, we probably didn't touch on it explicitly, but I think the other area in rehab we really had to advocate for was to have essential care providers come in to be able to learn skills. So at the beginning, it was absolutely no visitors, no family, or very limited visits. But so we really needed to highlight the importance of people learning how to do things. So you can imagine, you can only do so much of teaching someone how to do intermittent catheterization or a bowel treatment over video. So that was where I think we really, as a program, really had to emphasize the importance of rehab and that it is essential for care providers to come in and learn some of those critical skills. So that was where I think we pushed a little bit as a program within our own organization to say this is important and we need to have family members come in if they're going to be a primary care provider.
That's great. We had a flurry of a few questions at the end, so I'll just pick in essence of time. But Allison Banks was just wondering if we could share the template you use for PODS. The whole presentation will be, you'll get a link on YouTube to things, but I'm not sure if we share it otherwise. Or if you guys would be willing to and we send it out. Lindsay, can you comment on that?
Yep, so anything that you want to share in addition to the presentation, we can post it on our network webpage, and we can put a link to it there. So if you're willing to share, we can definitely share with the rest of the group.
Definitely.
And we'll just have time for one more. So Rebecca McKenzie said, if someone wasn't able to accurately respond to enough questions about their care, did that ever change their discharge date? I guess did you have to?
Yeah. In very few cases, it did change their discharge date, but the whole intention of having the patient meeting a week before discharge is to ensure that the gaps that exist in knowledge and understanding, we have time to close those gaps before discharge. So there have been people who, I don't know what medication I'm taking, I don't know where I'm going to get my meds, I don't know how to pressure relieve, I don't know how to get up from the floor if I fall. We still have that week from the point of the meeting to discharge to close those gaps and increase confidence in the discharge plan. So it didn't happen very often. I can probably count on one hand since 2015, but that's the intention of the timing.
And I think the other piece around that was making sure we scheduled PODS once it was a confirmed discharge date, because I think there was a few times a PODS would get scheduled a week before someone's tentative discharge date, but then you would find out that that discharge date wasn't going to happen. The patient still hadn't had a confirmed discharge location. So we always really tried to push it to when things were confirmed. And then it really is those kind of last minutes, you know, confirming that patient's been referred for outpatient physio, where they're going to get their GU supplies, that kind of thing.
Great, thanks so much. In the essence of time, Sandra and Heather have put their emails in the chat, and I think we can probably, Lindsay, we can probably send it out to people. So if you do have other questions, if you would be okay fielding some questions that way.
Sure,
definitely.
Yeah. Thank you so much for being part of this webinar series. It's been so informative and so appreciative of you doing this. Keep tuned in, everybody. As mentioned, there is another webinar coming up in August, and then our network summit will be in September, so you'll receive some information about that. And everyone have a good day, and thanks for joining.
Thank you.
Bye.
Bye.